Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, founder and CEO of the Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making scalable impact on global equity. Join me in insightful conversations with healthcare innovators and advocates from around the world as we explore the current and future state of healthcare. Be a part of the mission. Let's create lasting change together. Today, I have the immense pleasure of speaking with one of those advocates, my friend and colleague, Stephine Ogutu.
Thank you, Kim. It's a pleasure to get to reconnect today on this very important platform that is creating opportunity for policy dialogue on ways to advance access to health for the most marginalized communities across the world.
And I'm going to tell you a little more about Stephine before we get into our conversation today. He's obtained his master's in development communications at the University of Nairobi and is the Kenya country director and East Africa coordinator for the Movement for Community-Led Development. In this role, he masterfully builds partnerships, is a liaison to government entities, and balances policy, sustainable development goals, and capacity building to spearhead projects aimed at local sustainable development goals. He also holds several volunteer roles, and that includes membership on the board of directors at the Global Telehealth Network. And it's in this last role that I had the pleasure to meet with Steve in person and spend a week traveling and working with him as we prepared for a telehealth network launch in Kenya and Uganda in partnership with the Global Telehealth Network. Steve is an advocate for community-led development. He's a healthcare and gender equity advocate. He's a government and policy development advocate. And he is surely a person to watch and follow as his present work and future are inspiring. We are very excited to have you on the podcast.
Thank you, Kim, for the kind introduction. And I'm really excited about us having these conversations that hopefully will change how we do things when it comes to things to do with health and all that, especially in this part of the world.
Yeah, let's get into that a little bit. First, tell us a little bit about you. How did you get into this role and becoming an advocate and a voice for equity in Kenya? And actually, you work in other countries in Africa as well. Tell us a little bit.
I started off my career sometime in 2012 in the nonprofit sector, and then around that time, I was with an entity called Global Communities, which is a US-based nonprofit that then works in a number of over 30 countries across the world. And it happened that they were implementing a program funded by PEPFAR to reduce new HIV infections among adolescent girls and young women, especially in the informal settlements of Nairobi and other parts of Kenya where that has a high HIV burden. And so, as a development, communication, and policy specialist, I interacted a lot with these victims or at risk groups, and just getting to listen to their stories and documenting those stories. And I witnessed a lot of resilience despite the kind of challenges that they encountered, especially when it came to access to drugs like the ARV and other HIV interventions, that the government offered and that development partners like PEPFAR offered. And so, seeing that gap and seeing the resilience that these young women, young people in general have really motivated me to remain within the development sector and utilize whatever space I found, whether it's an opportunity to speak to the media and other advocacy platforms, meeting with governments and all that, to raise these issues with them, so that they are repeatedly reminded that it is very important to prioritize health access, especially for the most marginalized in our communities.
Steve, even when I met you in Kenya, it was clear that you're very driven and motivated by helping women and girls, especially in other marginalized communities. You pull a lot of motivation from those communities. We met with widows who were displaced from their property. We met with indigenous populations that were having their land also being displaced and having land rights issues with the government. And it was very clear that you really step outside of yourself and try to learn what these communities are going through, what they need, and be an advocate. Where do you think that started?
I would say it's my interaction with these communities from when I was growing up. It was also around the time when I started off my career in the development sector, and just witnessing the kind of suffering that these women and girls in general face, especially those that are based in underreached and underserved areas. Mostly when INGOs come to places like Kenya, they set up shops in Nairobi, which is the capital city, of course, because it's convenient in many ways. But what this does is people who need these services the most, who are in far off places like where we visited when we were here, don't get to access these opportunities, be it in terms of training, be it in terms of just access to these services. It becomes a challenge, and therefore, someone has to step in to be a bridge, and to bring up this partnership. Like what now the Health Alliance for Equitable World and the Global Telehealth Network, where I serve on the board, are trying to do, and connecting partners like you with governments, local governments in those rural areas, to be able to come up, co-create a solution that centers the communities and women and girls and youth in these initiatives. And I find that very fulfilling, because for me, I always say that that could have been my mom, or that could have been my sister or my brother, or it could have been me. And so that is the lens through which I look at how that really informs how I approach things in life.
Steve, that's beautiful, and this is going to be a little bit of a let's admire Steve's wonderful work session, because what I noticed of you is that in the world you can either be a victim or you can be self empowered, and you really have taken what privilege you have, right? The privilege of being a man and being able to get an education and be connected to these government entities, and decided to use that in a very powerful way to uplift marginalized communities. There's certainly lots of other choices people could make. I must imagine you come from a family and a community for which that's really important to make that such a fierce embedded part of who you are.
Right, right. And yeah, so for me, I think just being able to work with communities, being able to see systems change, being able to be part of a process that makes things better for communities. Uh, it really inspires me, you know. When now, maybe through the interventions that we are working on with the Health Alliance for Equitable World and GTN, say if women in the rural part of Makueni County or Vihiga County or Sierra County where you visited when you're here, or Nakuru County where you visited when you're here, are able to have safe delivery, and their children. You remember, there's a group that we visited within the gay community of this woman who was sharing her story. There were actually women who were sharing their stories, and this woman pointed out that in there they have a clinic there that is government sponsored, and in that facility, children die when they turn about 4 weeks, and and mostly it's because of many factors, including the technical capacity, the speciality needed to handle such cases. But with this kind of innovation that the Health Alliance for Equitable World is bringing on board, that is able to provide the technical support to medical doctors, I mean, to healthcare workers in places like those ones, and provide that mentorship and training, is going to help reduce these cases and have women deliver safely. I think there can be nothing as satisfying as that. As a mother saying, okay, this before we could deliver, give birth, and then after 4 weeks, our children die. But this is my child 5 years later, 10 years later, and they're thriving and succeeding. And I think for me, that is very fulfilling.
Yeah, definitely. And maybe we can talk a little bit about that. So what we're talking about is bringing um, an intervention to a community that they're asking for support for the local healthcare clinic, and maybe we can talk a little bit about how healthcare is set up in Kenya, and how this becomes a local initiative, right? Because I think devolution, which you are an expert in, is an important part of how that is a local um, initiative, and how it's the relationships with the local government that drive that. But here's a community that at a local healthcare clinic level has a nurse to hopefully a nurse to help women deliver babies. The community is scared. They don't trust the local clinic. They would rather deliver at home because they're seeing these um, mortality rates of their infants who come home seeming normal and then die within um, 1 to 2 months, and asking, is there something you can do to help us? And so we have a telehealth network. We have this community that we're building with the Healthcare Alliance, and we've formed partnerships like what you're talking about with a tech company to give us their telehealth platform to use for this purpose. We have in some locations, there's solar power already in place. There's laptops, and so having the infrastructure, then the government relationships. So the next step, making sure you have those relationships, and that you have the right permissions, and that you don't run afoul of local regulations, and then making it a community empowerment, not bypassing the local healthcare system, but finding a way to include and support the local healthcare system so that they have more capacity and they have more skill, and that they can help um, bring better outcomes for the patients.
Yeah, that's really a good background that you've said there, Kim. And maybe just to paint a context of the Kenya system, we have our new constitution. It's actually no longer new because it was promulgated in 2010. It's the most recent, so we still call it new. So with this new constitution, it introduced devolved system of government, or what you call in the U.S. states. So in Kenya, we now have from a unitary state to now unitary country to now 47 states, and these 47 county governments. Uh, there are certain key functions that were devolved under the Schedule 4 of our Constitution, one of them being health. And the reason why this happened is because previously, even for very basic surgeries and treatment, someone had to travel miles, several kilometers or miles to get to Nairobi, which is the capital city of Kenya and where most advanced health services are situated. But with devolution, the idea was to decentralize these services, to take them closer to the people. But also, what this did is, yes, we devolve functions, uh, but less funding was also devolved that doesn't meet the devolved functions. And therefore, you will see some hospitals that are very beautiful but don't have pharmaceuticals, or don't have enough healthcare workers. And that doesn't help at all. Recently, we saw what happened with the U.S. withdrawal in most parts of the world. Kenya was worst hit. You heard during our courtesy session with the governor of Vihiga County, Governor Dr. Otichilo, he mentioned that in his county alone, about 300 healthcare workers who are on USID health programs that were supporting the county are no longer there because there is no funding to take care of that. And that is the same case in Makueni County, where we also visited. And that is a shared story across the 47 counties, and it paints a very grim picture. And therefore, the kind of intervention that the Health Alliance for Equitable World and GTN are really bringing on board, um, it's coming at a very timely moment, because one, it's less expensive, even for governments, and for the MOUs that we're going to be signing with the government of Vihiga and Makueni here in Nairobi and others that have expressed interest, as you know, Kim. Um, it's because they see it that way. They see it's less expensive, but gives them quality in terms of healthcare access. Um, and then you also have very experienced and some unique specialities within the doctors that you have within your panel. And that knowledge transfer is very important for the medical fraternity specialists here in the country. And therefore, um, this is going to be a game changer. And I'm excited about how things are already rolling out. Just recently, as you may have seen, I was in a meeting with the governor of Makueni County about 3 weeks ago, and he was just sharing with me about the report he got during our visit, and what we are putting up together in line with the MOU that we had to sign and the support that you are all bringing on board. And he's super excited. It's a life changing initiative that we are very grateful about as a country.
You said so many important things that I really want to stress for our audience. Um, USAID funding cuts are having a real and life changing impact on these county governments and the county medical systems. with hundreds of healthcare personnel no longer being available within the system, especially around things like HIV. Secondly, that with a devolved healthcare system and counties carrying healthcare as the key function, they have to find ways to bring more healthcare with a not a national budget but a local budget, and that telehealth helps really fulfill that role because of low cost in terms of especially personnel, and low cost especially in terms of infrastructure, and for speed and ability to put the structures in place in a short period of time so people don't have to wait for construction for 10 years and hope that they have better health care at that time. I mean, so many super important things. I have to say, I was also super impressed at how much the governors of Vihiga and McQueen County and the other government officials we met, how motivated they truly were to use what they have in their capacity as the county government to bring better health care and to partner to do innovative things, to really improve healthcare in a real life um, short period of time. The governor talked about things they did to help bring women into prenatal care and to encourage women to deliver in hospitals, and doing this not to just generate business for hospitals, but to improve maternal and child mortality, and using their county experience with that to then bring that up to the national level as a national initiative to improve healthcare. It's quite innovative, and very impressed by the government entities we've met that are really pushing innovation in this area.
And I think this is a model that uh, once we work on it, and like what we are already starting with the Higa and Makweli County, this is a model that even the national government would be very happy to pick it. As you may know, we are also in chat in talks with the Ministry of Health through the Director General of Health. And right now, the national government focus is on achieving the universal health coverage. But with all these cuts within the development sector and with the high burden of debt that Kenya and most countries in Africa are experiencing, I'll just paint a picture of Kenya. In Kenya right now, when it comes to debt issue, 70, 70 cents out of every dollar we collect goes to debt. Okay. So we only have about 30%, 30 cents that is to go to recurrent expenditure like salaries. And that is also supposed to go to county governments and other development initiatives. And some of them are capital intensive, like infrastructure. 30% that I'm talking about. And so it tells you where the health allocation is. Yet this is a very important part of a country's economy. We say that a healthy nation is a prosperous nation. And when there is very meager allocation of resources to this important sector, then it becomes expensive in the long run because citizens can never afford access to healthcare. There's a burden on relatives and families, and that goes all the way to the national government, and it becomes a burden for the nation. And therefore, one of the conversations that we are having, Kim, as you're aware, is to also see how we can extend the telehealth support to the national government, uh, work with the Ministry of Health to build their capacity. One, to install the systems around telehealth, but also build their capacity. Maybe use the experience that you bring on board and the experts that you're bringing on board to even build a TOT, a train of trainer model. And that is important for sustainability because even when you are not there, at least we have some capacity locally to carry on with the important initiative seed that you planted here. And so I'm saying this to say that this intervention and this collaboration that you're having now in Kenya has come in at a very timely moment. It's going to save a lot of lives. It's going to reduce mortality rates. It's going to improve the quality of life for the country and in general um, serve the most underserved and underreached people who cannot afford to the expensive healthcare that we have as of now in the country and in the continent.
Steve, that wow, you are really from a very grounded and knowing place, validating all the things that we predicted and hoped we could do with this intervention, which is really important. And just for people listening, to be clear, the way that a global network of physicians, physical therapists, other specialists, right? Psychiatrists, dentists, we even have teledentists on our network, can build capacity isn't just through consulting with local healthcare teams, right? But you're building their capacity and their knowledge base, right, for different specialties and for different conditions. But one of the things that these telehealth networks do is also build local networks that didn't exist before. So we are connecting rural clinics with regional hospitals and with local hospitals that weren't connected before, so that within the county and within the country, they can support each other outside of our network. So it's building capacity within the country and then having our team as support for the things that they don't already have. So I just wanted to make that clear for folks listening, what we're talking about. Um, and I think with that, we're going to take a tiny little break. I am really enjoying your this conversation, your expertise, your perspective is wonderful. Let's take a quick 2 minutes.